This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined today by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal Child's Nervous System, scheduled for the March 2026 issue. It's titled Outcomes in Children Receiving Single-Fraction Gamma Knife Radiosurgery for Arteriovenous Malformation.
This is a crucial topic, Ilara. We know that arteriovenous malformations, or AVMs, are a leading cause of non-traumatic intracranial hemorrhage in the pediatric population. While microsurgical extirpation is often the first thought for many of us due to that high rate of immediate nidus obliteration, it's not always the best or even a feasible option, especially in surgically challenging locations.
Exactly. And that's where stereotactic radiosurgery, or SRS, comes in. Historically, the data on pediatric AVM outcomes with SRS has been a bit heterogeneous. We've seen reported obliteration rates ranging anywhere from 64% to 77% at 5 years. But the authors of this study felt those numbers, particularly from some of the larger multi-center registries, didn't quite match their clinical experience. They suspected their institutional outcomes were actually superior.
Right. They hypothesized that their obliteration rates exceeded those previously reported. So they looked at a 2-decade-long institutional experience, specifically from January 2006 to December 2023. Let's dive into the methodology. Who was included in this cohort?
The study reviewed 89 patients, which accounted for 101 AVMs. The age range was quite broad, from as young as 2.36 years up to about 20 years old, with an average age of 12.9. What's notable here is the homogeneity of the treatment. Every patient received single-fraction gamma knife SRS. They excluded anyone who had multi-fraction stereotactic radiotherapy or multi-staged SRS.
That's an important distinction for the data's purity. Let's talk about the procedure itself. I noticed they used a very specific workflow for targeting.
Yes, they used stereotactic head frame placement under general anesthesia. For targeting, they fused high-resolution MR angiograms, or MRA, with intra-arterial digital subtraction angiograms, or DSA. In some cases, they even added CT angiogram. The planning goals were strict. They aimed for a selectivity greater than 0.8 and coverage greater than 0.95. The margin dose was typically 20 gray, and they never went below 18 gray.
Those are solid parameters. And before we get to the results, let's paint a picture of these AVMs. Were these easy cases, or were they the complex ones we often see referred for radiosurgery?
They were definitely complex. About 65.3% of these AVMs involved eloquent areas, and 56.4% had deep venous drainage. The average volume was 2.85 cubic centimeters, though they ranged from tiny nidi of 0.034 up to nearly 25 cubic centimeters. In terms of Spetzler-Martin grading, the majority were grade 2 or 3. That's 39.6% and 36.6% respectively. Interestingly, 70.8% of these patients presented with a pre-SRS hemorrhage.
So these are high-risk lesions. Now, the big question for our listeners, how well did the SRS actually work? What were the obliteration rates?
The results were impressive. They looked at radiographic obliteration, which they defined as the absence of a nidus or flow void on MRA, or confirmed angiographic obliteration on DSA. At 3 years, the obliteration rate was 55%. By 4 years, it jumped to 73.1%. And at 5 years, it reached 83%.
That's a significant upward trend. And if we look at the patients who had long-term follow-up, the ones followed for more than 36 months, what did that look like?
For that long-term group, where the median follow-up was 85 months, the obliteration rate after SRS alone was 90.6%.
90.6%. That is notably higher than the 68 to 77% ranges we see in older literature. But of course, in neurosurgery, we know that some AVMs are stubborn. What happened to the cases that didn't obliterate after the first round?
8 AVMs, about 7.9% of the total, failed to obliterate by the 3-year mark and required salvage therapy. 5 of those were retreated with a second round of SRS, 2 underwent embolization, and 1 was surgically resected. The success rate for those retreatments was high. 7 of 8 were successfully obliterated. When you factor those in, the overall obliteration rate for the entire cohort rose to a staggering 97.6%.
That is an excellent outcome for a pediatric population. But as we always tell our residents, effective is only half the story. We have to talk about safe. Pediatric patients have a long life expectancy, so we worry about long-term toxicities, especially radiation-induced ones. What did the safety data show?
This is perhaps the most encouraging part of the study. Over the entire follow-up period, which went up to 193 months for some patients, there were 0 cases of secondary malignancy.
0? That's a major point for counseling parents who are often terrified of the word radiation.
Exactly. Furthermore, no patients died post-SRS, and there were no post-treatment hemorrhages recorded. However, it wasn't entirely without side effects. They did see symptomatic radiation necrosis in 7 patients, which is about 8.5%.
8.5% for symptomatic RN is within the expected range, but still something we have to manage. What about functional outcomes, seizures and neurological deficits?
At the last follow-up, 13% of patients had residual seizures, and 14.6% had persistent headaches. A larger portion, 39%, were noted to have neurologic deficits. It's important to remember, though, that many of these patients had these deficits or seizure disorders prior to the SRS, given that 70.8% had already suffered a hemorrhage.
That's a vital context. We aren't necessarily seeing new deficits in 39% of patients. Rather, we are seeing the sequelae of the original AVM presentation in a population that has now been protected from future bleeds.
Right. The study mentions that 37.1% had a neurologic deficit at presentation, which aligns closely with that 39% figure at follow-up.
Let's talk about the follow-up protocol the authors used. It seemed quite rigorous.
It was. They did MRA every 6 months post-SRS. Then they performed a DSA at 3 years, or sooner if the MRA suggested obliteration. Once obliteration was confirmed on that gold standard DSA, they didn't just stop. They continued MRA evaluations at 5 and 10 years to ensure stability.
That rigor is likely why their data is so clean. They defined angiographic obliteration strictly as the absence of anomalous arteriovenous shunting. When you use such high-resolution imaging and a 2-decade window, you get a very clear picture of the latency period, that window of time between the treatment and the actual obliteration.
And throughout that latency period, as we mentioned, they saw no hemorrhages. This suggests that even before total obliteration is visualized, there might be some protective remodeling occurring, though the study focused primarily on the final obliteration rates.
So if you're a resident or a student listening to this, what's the big takeaway for clinical practice?
I think it's that single fraction SRS is not just a second best option. In this large single institution cohort, it proved to be highly effective, with an 83% obliteration rate at 5 years, which can be pushed to nearly 98% with salvage therapy. And the safety profile, specifically the lack of secondary malignancies and post-SRS bleeds, is very reassuring for the pediatric population.
It really challenges the idea that pediatric AVMs are more resistant to radiation than adult ones. The authors successfully showed that with precise targeting, using that MRA and DSA fusion, and consistent dosing of 18 to 20 gray, you can achieve results that rival or exceed multicenter registries.
One final detail I found interesting was the role of pre-SRS intervention. Most of their patients, about 71.9%, had no intervention before the gamma knife. Only 13.5% were embolized, and 7.9% had a prior resection attempt. It shows that SRS can stand alone as a primary treatment modality for these children.
Excellent. Well, this has been a great dive into a very relevant paper. For our listeners, the key is the balance of high efficacy and a low rate of serious complications.
Definitely. And for those interested in the specifics of the targeting selectivity and coverage, I highly recommend reading the full text in Child's Nervous System.
Thank you, Dr. Alara, and thank you all for tuning in to the Neurosurgery Hub podcast. We'll see you in the next episode.
Goodbye, everyone.